And good morning, everyone, or good afternoon. We're welcome, everyone. We're delighted to have you join us for today's webinar with REGENXBIO, who will be sharing the latest results from their phase 1/2 AFFINITY Duchenne clinical study with RGX-202 in patients with Duchenne muscular dystrophy. I'm Michael Kelly. I'm the Chief Scientific Officer at Cure Duchenne, and I'm going to get started with a bit of housekeeping. We will have an opportunity for Q&A today, and you can click on the Q&A button at the bottom of the screen and submit a question anytime throughout today's presentation. We'll also have a moderated Q&A session at the end of the webinar, and I'll be joined by my colleague, Dr. Liana Orlando, our VP of Research. For those questions that we don't get to, we'll work with the REGENXBIO team to follow up with you after the webinar. After today, this webinar will be available on Cure Duchenne's website as a resource to the community in case you'd like to share it with others. So let me begin. REGENXBIO's approach to gene therapy as a treatment for Duchenne utilizes a unique microdystrophin gene that has been specifically designed to include an extra feature of the important C-terminal region of the dystrophin gene. As a result, RGX-202 microdystrophin is larger than other gene constructs, and because of this, we've been following their clinical trial closely to better understand how the enlarged microdystrophin gene would function in patients. REGENXBIO is currently recruiting the pivotal phase 3 portion of the trial and is expected to complete its enrollment later this year, following which they plan to file a biological licensing application for accelerated approval in the United States about 12 months from today. To talk more about this and the recent results, we've got Dr. Naz Dazgir, the clinical development lead at REGENXBIO, to walk through the new interim functional data from the phase 1/2 AFFINITY Duchenne trial. So without further ado, let me hand it over to Naz to get things started from here.
Thank you, Mike. And thank you to everybody for listening in today. It's a pleasure to be speaking to all of you. So I'm going to get started and go through the slides, and then we'll have a Q&A session at the end of this call, and I'm happy to field whatever questions you have about the study. So we'll be talking about RGX-202 and the AFFINITY Duchenne study. We have some new phase 1/2 interim functional data to share. And my background is that I'm an executive director and clinical development lead of the RGX-202 program at REGENXBIO. These are our forward-looking statements. Right. Oops, sorry. So RGX-202 is an investigational AAV gene therapy designed to address the lack of functional dystrophin. So here you can see a little schematic that shows the AAV8 vector that we use to deliver the transgene to both skeletal and heart muscles in the body. We use an SPC512 muscle-specific promoter that's intended to drive the expression of the transgene in muscles. And we have a unique microdystrophin transgene that is expected to encode a novel protein designed to retain key elements of the full-length dystrophin, including the C-terminal domain, which is what Dr. Kelly mentioned earlier. So the C-terminal domain is going to be right here in red. And that, if you compare different microdystrophin genes between companies, is one of the unique features of our drug. It's given as a one-time IV infusion to patients who are eligible for our study. So going into how we compare to other companies, so as I mentioned, we have the C-terminal domain here highlighted in green this time, and we use a different vector than most. Genethon has one similar vector to ours. We also use SPC512 as a promoter, and that promoter is a bit smaller, so it allows us to package more of this synthetic transgene into our cassette. And basically, we pick and choose the parts that we think would be most helpful to the stability of the protein and the function of the protein. And so that is what makes our microdystrophin transgene different. And every company's microdystrophin transgene is a little bit different, but typically based off of what is thought to be important for maintaining some ambulatory function later in life based on some Becker muscular dystrophy patients. Preclinical studies indicate that the C-terminal domain in RGX-202 microdystrophin preserves muscle health and enables muscle resilience. So how the TCT domain may contribute to improved outcomes. It may allow for prolonged microdystrophin activity. The C-terminal domain significantly enhances restoration of the dystrophin-associated protein complex by stabilizing the microdystrophin in the muscle cells and potentially allowing it to accumulate at higher levels and act for extended periods of time. The CT domain in RGX-202 microdystrophin also protected against contraction-induced damage, enabling better muscle recovery. So contraction-induced damage is typically from eccentric muscle contractions, such as, for example, if you did a bicep curl and you're putting a weight against an extended muscle, that is an eccentric contraction. And so here you'll see on the right that we did a study in mice where we checked to see after 20 eccentric contractions, are you able to generate, what percentage of initial force are you able to generate? And here in gray, you will see what the DMD mice were able to generate. So at the beginning, before the eccentric contractions during that trial period, they were at 100%. And then basically they dropped down to below 20% after 20 eccentric contractions. Well, if you give our transgene without the CT domain included, we get to around 40%. But when we included the CT domain, we got closer to 60%. So it was based off of that we made the decision to include the C-terminal domain in our transgene. What you see highlighted in white circles here are the control mice who are not affected by Duchenne muscular dystrophy. So after that background, I'm going to step into some of our data from our phase 1/2 study. So as you know, phase 1/2 studies typically are in place to check the safety of a drug and also test some ways that we can better learn about efficacy, particularly in the phase 3 study. So this was a dose escalation and expansion study. The key eligibility criteria were boys ages 1 to less than 12. So we first started with 4 to less than 12, but then we opened it up to 1 to less than 12. They needed to have genetically confirmed Duchenne muscular dystrophy with mutations in exons 18 and above. They needed to have no pre-existing antibodies to the AAV8 capsid. And the inclusion criteria were a little different for those who were less than 4 versus those who were older than 4. And that's mainly because some little children can't participate in the same outcomes, or we have less expectations for them in terms of the outcomes. So they just needed to be able, the less than 4-year-old children needed to be able to complete a 10-meter walk without assistance and get up from the ground on their own. And we actually allowed them to be on or off steroids from the start, but we requested that they stay on or off steroids for the duration of the study so that we can check how they performed on or off steroids at the beginning of the study prior to dosing with RGX-202 to how they performed later in the study after receiving RGX-202. And then we required that these children be greater than 10 kilograms, mainly just because we have to draw a lot of safety labs for the study, and there's a certain volume limit that we can draw on children, and 10 kilos was the lowest we can go in terms of how much volume we needed for the safety labs that we needed for this portion of the study. For the 4 and older patients, they needed to be able to complete the 100-meter walk without assistance and be on a stable dose of corticosteroids for 12 weeks. What we have in our study also is a proactive immune modulation regimen. So this is a little bit more than what you might see with other gene therapies, commercial or research-based. So, but we instituted this for consistent improved safety outcomes. So we prophylactically, meaning preventatively, initiate a drug called eculizumab, which is a C5 inhibitor. C5 is part of the complement system, which helps your immune system fight infections. But sometimes with that immune response to fighting infections and whatnot, you get this inflammatory response. So sometimes the way the body responds to the vector therapy is to kind of fight with an immune system response, and the complement levels may go up. And so you want them to go up. It's normal for them to go up, but you don't want them to go up too high, and you don't want it to be sustained for too long, because that's when you start to see the different side effects that can sometimes happen with gene therapy. So that's why we prophylactically or preventatively start kids on eculizumab, which is a complement C5, complement 5 inhibitor. We also start the kids on some sirolimus, and prednisone. This is weight-based therapy. We put you on full dose of these drugs. Typically, the eculizumab ends at around day 12, and it's about 5 doses on average, depending on the weight of the child. If the child is heavier, they might need a little bit more. But they'll stay on this dose. And then after the 2-month period on average, what happens with the other drugs, the 2 months full dose of sirolimus and prednisone, that third month is used to wean off of the drug. And what we found is that it's intense. There's a lot of monitoring that goes on at that time, but it feels safe, it feels good because we know that we're acting preventatively, and we've had a really great safety profile instituting this therapy. It's been really well tolerated as well. So we use this as a potential to reduce the reactive safety, the safety issues that might come up with the institution of gene therapy. As I said before, the primary endpoint of our study was safety. We also checked a biomarker endpoint known as microdystrophin expression. So that's to see how much of so the transgene creates the protein, which is RGX-202 microdystrophin, and that microdystrophin can be quantified within the muscle tissue with a Western blot study. So that's where we can quantify how much microdystrophin there is, and quantification is with the Western blot, and then I'll show you some data later that shows the localization, which is more on immunostaining. And then secondary endpoints include muscle function, such as time to stand, how long it takes you to stand, how long it takes you to walk 10 meters, how long it takes you to climb 4 stairs. So we're comparing baseline to different time points over the course of the study. And the North Star Ambulatory Assessment, which is a series of motor function assessments that you do that then lead to an entire score that we could track over time. The North Star is used for those that are 4 and older, although we may use it in some of the younger patients just as an exploratory outcome. But in the younger patients that are less than 4, we focused on the Peabody Developmental Motor Scale. So let me go through some of the demographics, safety, and biomarkers of our study. So just to give you an idea of what types of patients we dosed. So as I mentioned, we had a dose escalation phase. So we started off with the lowest predicted effective dose of drug, which was our dose level 1 times 10 to the 14th genome copies per kilogram. And then we moved to dose level 2, which is 2 times 10 to the 14th genome copies per kilogram. And you can see that with that higher dose, we've dosed a child who's up to 35.5 kilograms with varying levels of function as defined by the functional outcome measures that we test in the study. So a wide variety of North Star scores, a wide variety of ranges of time to stand seconds, the 10-meter walk seconds, and the time to climb seconds. And the age that we dosed, so inclusion was up until 12 years of age. And we had one child that just turned 12 right after dosing. So he was dosed at 12.1 years of age. And we're very pleased to say that in our phase 1/2 study, we had no serious adverse events or adverse events of special interest. And adverse events of special interest just relates to specific adverse events that we as a company are interested in following, particularly because they've been described in the history of administering gene therapy to begin with. So that includes central or peripheral neurotoxicity, drug-induced liver injury, thrombocytopenia, which is a low platelet count, myocarditis, which is inflammation of the heart, or myositis, which is inflammation of muscle tissue beyond what you would expect with Duchenne muscular dystrophy. The most common drug-related adverse event that we had in our study, in our phase 1/2 study, was nausea, vomiting, and fatigue. And so overall, we can say that RGX-202 has been very well tolerated in the phase 1/2 patients at both dose levels, with no serious adverse events or adverse events of special interest. So this is the biomarker data that I was alluding to earlier. So again, we have biomarker data for our dose level 1 patients, and then biomarker data for our dose level 2 patients. I'm going to focus on dose level 2 because that's the dose that we're moving forward with in our study. So dose level 2, you can see the wide variety of ages that we tested, and I'd like you to particularly focus on the fact that we have given our drug to 5 kids that are between the ages of 8 and 11. So these are older kids with more advanced Duchenne muscular dystrophy. And we've had really great outcomes. So the RGX-202 microdystrophin as quantified by Western blot, so quantifying the protein that's made by our transgene, ranges, the average for the 1 to 3-year-olds is 120.5% of normal dystrophin. For the 4 to 7-year-olds, it's 54.3%. And for the 8 to 11-year-olds, it's 39.7%. And we report this as a percent normal dystrophin, so what you expect to be normal dystrophin, and that's why that 120 might be a little bit higher. So you're 120% of what your normal is. Because this is quantification of microdystrophin and not dystrophin. And then we have vector copy numbers. So vector copy numbers is how many copies of vector we have per nucleus of cells, nuclei of cells. So basically here you can see we have a really good value here. I hope you can take my word for it. If you compare it to other studies, we have really good vector copy numbers in our muscle tissue. And you can actually see somewhat of a dose response here, where the kids who are receiving dose level 2 have a higher vector copy number than those who receive dose level 1. In terms of the positive fibers, I'd ask you to look over at the image on the right here, and this is the immunostaining that I was talking about. So immunostaining means that you have an antibody to the region of the microdystrophin, and basically you stain your muscle tissue with this antibody stain. And then that antibody stain can light up under certain imaging and immunofluorescence. It's tagged to light up under immunofluorescence. And what that shows is that not only is our drug quantifiable from the muscle tissue once it gets digested for the DNA extract, for the extraction of the protein itself, but it also gets to the right place. So all of these little circles that you see here, these kind of polygonal shapes, these are individual muscle fibers within the muscle tissue, and you could see that the muscle fibers are rimmed and ringed with the microdystrophin that we've given to a patient, and that's as early as 12 weeks. All right, so beyond the biomarker data, I'll move on to the functional data. So before we go on and show you the functional data, I'm going to show you how we're presenting the functional data. So basically, I'll read through the slide here. So phase 1/2 functional data natural history control methodology is how we're kind of showing you what the natural history control is that we're doing, because we do not have a placebo control in our study. This is a phase 1/2 study. RGX-202 dose level 2 recipients are expected to be stable or in a decline phase of trajectory. So if you look over here to the left, that this is an extract, a figure that's extracted from a paper from Dr. Mattoni in 2019. And basically it shows the North Star ambulatory assessment points and how those change over time. And you can see that, and you probably have experience with your child or your loved ones or patients that you care for, that kids with Duchenne may actually have some, very early on, they may have some signs of nonspecific developmental delays. But then over time, they start to get a little bit better. There might be some improvement. But once they hit around 6 years of age, there's a little bit of a decline, like a turn towards a decline in motor function that takes place. Now, that's not 100% that at 6 years of age this is going to happen, but this is like on average. So what this little dotted box here shows is that our patients in this study are encapsulated within this period of time, because we're dosing, the cohorts that we're showing you are a little bit older. So we're at that limited peak performance period, and then the period of rapid decline that you expect up until the age of 12. So our dose level 2 functional data set for the N=5, ages 5.8 to 12.1. For 9 months post-dosing, we have data to show on 5 patients. And I'd like to note that 4 of those 5 patients that we're going to show you today are over the age of 8 at dosing. At 12 months post-dosing, we have 4 patients to show data on out of those 5, and 3 of those 4 are 8 plus. And I'd like to also note that the 9 and 12-month time points are 6 to 9 months after the immune modulation regimen ends. So we believe that this is outside the realm of the influence of the additional immune modulation we give for the safety of administering the gene therapy. Now, that is the group that we're going to show you data on. How we compare to external control is a different story. So what we have is exact matched natural history external controls. There's heterogeneity that's present across baseline disease stage, rate of disease progression, and anticipated efficacy response in all patients. But what we do is we strictly match our patients to controls from a natural history data set that at this time we hope to includes 402 patients. And we match these children based on their age and baseline function. So we'll take a child that's enrolled in our study and we'll match to the number of patients that are available with the same age and baseline function as it pertains to the time to stand, the 10-meter walk run, and the time to climb, and obviously steroid use as well. And then we see how that patient in the natural history cohort or that group of patients in the natural history cohort performs 9 months out, 12 months out, and we compare how our individual patients perform compared to them. So what you see in this slide in the gray bar is the natural history external control, okay? But what we see in the blue bar is how our patients on average are changing from baseline. So improvement is moving upward here, and we'll start with the individual values, and these little kind of staple looking error bars here show you the range, and what we're presenting to you is the average. So for the timed functioning test, for example, the time to stand, the delta or the triangle that you see here is a comparison of what the child did at 9 months on their time function test or NSAA compared to what they would be expected to do 9 months later, because we know that Duchenne is a progressive disease and there is a decline phase that happens in the majority of the patients that we're treating in our study. So as you can see here, for the time to stand, they improved by 1.7 seconds. For the 10-meter walk run, they improved by 0.9 seconds. And for the time to climb, they improved by 1.3 seconds. And for the NSAA or the North Star Ambulatory Assessment, they improved by 4.8 seconds, all compared to natural history control. But there's still an improvement compared to baseline as well. At 12 months, doing the same comparison again, gray bar, natural history, external control, blue bar is the patient compared to their baseline. You can see that at 12 months, we have sustained improvement. So there's an improvement of 1.6 seconds in the time to stand. 10-meter walk is improved by 1.1 second. Time to climb is improved by 1.2 seconds. And the North Star is improved by 6.8 points, which to me, as a clinician myself, as a neuromuscular specialist, is great because I'm always expecting to see worsening after a certain age. And as I mentioned before, 3 of these 4 patients are over the age of 8. So this is really reassuring to me that we're performing well, not only in all age ranges, but especially in the older age group. The other thing I'm going to show you here is our time task velocity. So it's not the absolute seconds, but how quickly they're able, the velocity, the rise per second in the time to stand, the meter per second in the 10-meter walk run, and the task per second, which is the task being climbing 4 stairs per second. And we're comparing this to a minimally clinically important difference. Minimally clinically important difference is a concept that was introduced from a paper by Tina Duong. It's referenced below, and it was referenced by the prior CBER director of the FDA in the approval for commercially available gene therapy in ambulatory boys. And so he referenced the MCID and how that drug performed compared to the MCID. So here we want to show you that ours is also surpassing the MCID, or the minimally clinically important difference. So the MCID is in this horizontal gray bar, and you can see how our 4 patients at 12 months are performing and compare that to that. The other thing that we find very important is we can have all these numbers on these motor function assessments, but how is this translating to how the parents are feeling when they learn about, when they see their child in the study? And so this is a reference that's taken from a paper by Craig McDonald about how the POTSI, a patient-reported outcome measure, changes over time. And here in the gray bar, you can see that extraction from that paper, and the blue bar is how our patients are doing in these 3 domains of the POTSI, which is transfer and basic mobility, sports and physical functioning, and global function. So caregiver-reported outcomes improved function in home and community as measured by the key dimensions of the POTSI at 12 months compared to the expected decline in natural history. So overall, the summary of the phase 1/2 study is that it's been well tolerated in 13 patients across both dose levels with no SAEs or AESIs. The biomarker data supports consistent, robust expression, transduction, and sarcolemmal localization, which is just getting that protein on the membrane of RGX-202 microdystrophin. The new functional data supports consistent evidence of RGX-202 altering the trajectory of disease, showing boys treated with dose level 2 demonstrated clinically meaningful improvement in function at 9 and 12 months, exceeded natural history external controls and MCID benchmarks, showed improved function in the home and community as reported by caregivers. So I'm now going to go into the phase 3 study design. So with learnings from the phase 1/2 study, we got some confidence based on safety data, and we're like, you know what? Why don't we just open this up a little bit more? We're going to open it up to boys that are 1 and older, with no upper limit of age, and let's open it up to more patients with more mutations. So at this point right now in our study, which is currently open and enrolling, this is not a placebo control study, this is an open label study, we will enroll any child with a deletion or point mutation in any mutation except in any exon except for exons 8, 9, and 10. We will take duplications in 8, 9, and 10. Now, the reason for this is because this has been established as a hot spot for concern for adverse events that could happen with the administration of gene therapy, but also it's a region of the dystrophin protein that might, if you're missing it, when we give the transgene to you, it may look so foreign that your body might have an immune response to it. Now, is this something that's hard and fast and going to be set in place for us forever? No. In fact, we try as a company to gain more confidence with dosing these other mutations. And if we feel like we have a good safety profile at that point, we have every intent in trying to move on to dose these other additional mutations in 8, 9, and 10. But at this time, we're taking a stepwise approach, but we always remember the families with 8, 9, and 10 deletions and point mutations. And we hope one day to be able to dose them. So please know that that's where we're coming from for the future, and we're a constantly evolving program and company. We still ask you to not have any pre-existing antibodies to the gene therapy. The inclusion criteria for the different age groups remains the same. The proactive immune modulation regimen remains the same. The endpoints are a little different because now safety is not our primary endpoint. So the primary endpoint is the proportion of patients with greater than or equal to 10% of RGX-202 microdystrophin levels. So we want to show that we have our drug presenting itself and quantifiable within muscle tissue at a level of greater than 10%, meaning that our drug is getting to the right place. And in conjunction with that, we're going to use supportive secondary endpoints, which are functional endpoints, which include the time function tests, the NSAA in the 4 and older patients, the P-body, and we introduced the stride velocity 95th centile, which is a wearable device that measures your stride velocity in the 1 to 4-year-old patients. And that stride velocity is also an exploratory endpoint for the 4 and older patients. And for those patients who can tolerate doing MRIs without sedation, we will be doing skeletal and cardiac muscle MRI. So these are the sites that are open and enrolling currently in the United States. We have Stanford, Children's Hospital of Colorado, UT Southwestern, Arkansas Children's Hospital of Richmond and Virginia Commonwealth University, and Lurie Children's. So in summary, the phase 3 portion of AFFINITY Duchenne's open label trial of RGX-202 is now enrolling. REGENXBIO expects to submit a biologic license application under the FDA's accelerated approval pathway in mid-2026. If you have more questions about our program beyond what I presented today, or any kind of Q&A questions that we have, you can always go to our website at www.regenxbiodmdtrials.com. Or you can also reach out to our advocacy team, email duchenne@regenxbio.com. And just one little plug here about our Affinity Beyond study. So this is a separate AAV8 antibody assessment study. We have a central primary investigator, Dr. Han Fan, working out of the Rare Disease Research Institute in Atlanta, Georgia. This is a study that is going to be updated very shortly. We put an amendment through for this to match our study. to allow for boys 0 to 25. But at this time, it's 0 to 11, but give it a couple, like give it a month. It'll be finalized. But basically, what's going to happen is if you're interested in a study and you don't want to just go to a study site to get assessed, um, or there's if one site says, I can screen you maybe in a month or two, and you're interested in getting screened sooner, you could reach out to Dr. Fan. This site is listed on clinicaltrials.gov, and what they could do is they could do this all over the phone and video conversation and basically video interview and talk to you, and then send a nurse out to your house. And that nurse will draw the blood, get the antibody assessment performed, and send you back the results. And this is just for AAV8 antibodies. So this way you can know if you're positive or negative, and that's one big step to knowing whether or not you're eligible for our study. So in the end, I just like to give some shout outs and acknowledgments to all the lovely investigators that we have on our study, all the amazing study coordinators, and obviously the REGENXBIO team. And of course, to all of you. And thanks again for your attention. And here's some QR codes if you'd like to look at the different sites on clinicaltrials.gov. I mentioned the website, www.regenxbiodmdtrials.com, and our email, duchenne@regenxbio.com. So I guess we can enter the Q&A session now.
Naz, thank you. That was a super presentation. You walked through that really well. Let me just continue to invite the audience. If you have questions, please go ahead and put them in right now. And I can see that I'm joined with Liana on this call. If I can take the privilege of asking the first question, Naz, I can see the way the company's working this through with the younger patients. Is there plans in the future to go to older, even more older non-ambulant individuals?
Yes, definitely. That's part of our evolution of our study. Obviously, right now we have to focus on this portion of the study, but as we open up more sites and we have more capacity to enroll more patients, we definitely want to focus on the non-ambulatory patients as well.
Yeah, thank you for that. And thank you for the way that the company has been very thoughtful about the way they've included patients in this and gone for the range that they've done, gone lower and now to older ones. So it's really appreciated. Liana?
Yeah, I mean, maybe we'll just continue with this just to reiterate sort of because the trial's recruiting, and so for people can think through whether or not they fall in. So any age 1 year older, but ambulatory, correct?
Mm-hmm.
With
Yep.
plans for non-ambulatory later. If someone has had a previous gene therapy, either in a clinical trial or commercial product, they would have neutralizing antibodies. It would not be able to get this, be in this trial or get this therapy.
Yeah, most likely. Well, there is some cross reactivity. It's not 100%. I don't think we've done much studies to see if someone receives one drug with because you can form like millions of antibodies to the drug once you receive it as gene therapy because you're getting such a high viral load. So it's unclear if you get like AAV RH74 or AAV9 gene therapy, if that will definitely cause you to be positive for AAV8 and our drug. But that being said, I feel like they're probably, I mean, this is me just talking out of, speculation, not any kind of research-based idea, but there's some concern that there could be some cross-reactivity to the product where if you have all of those antibodies positive, then that could introduce a safety risk with giving the drug if you do that.
Okay. And certainly for the clinical trial, you would be excluded if you received another gene therapy product.
Correct. Yeah.
Correct. And so there's also some questions around other drugs that you could be on. So let's start with steroids. Can someone be on deflazacort, or does it have to be prednisone?
They can be on deflazacort, they can be on prednisone or prednisolone, or they can be on vamorolone. Vamorolone's a little different. We evolve the program again to allow for its inclusion once vamorolone was approved. But we just don't give vamorolone at the same time as the additional prednisone immune suppression. So you just have to kind of switch off of it convert back to prednisone for a while. Then you can go back onto for that time where we have the additional immune suppression with the prednisone. And then once you stop that additional immune suppression with the prednisone, you can go back on the vamorolone. So we make sure that your baseline assessments are performed on the vamorolone and your follow-up assessments are performed on the vamorolone as well.
That's terrific. So no matter which version of them they're taking, you have the opportunity, if you qualify otherwise, for this to be in this clinical trial, and you will have to switch during the period of getting the gene therapy, but if you're on vamorolone, but
Right.
for anything else, the point is to actually get you back to what you were on to begin with.
Correct.
Perfect. And there's a question about Givinostat. How are you handling any individuals who are on Givinostat or not for the
Yeah,
clinical
that's a
trial?
great question. So there is a risk of thrombocytopenia or a decreased platelet count with any gene therapy that you get. That risk also exists with the administration of Givinostat. So at this time, we don't feel comfortable giving you gene therapy while you are under the influence of Givinostat, which means that you would just have to have a washout period of 3 months prior to entering the study, having your baseline assessments off Givinostat, and then getting the drug. And then you can restart the Givinostat at a later date, but ideally not in the context of the study, so that we can continue to see how our drug does in independent of the use of Givinostat. So you could have been on Givinostat, but we would ask you to wash out for at least 3 months prior.
Got it. And then one last question about the AAV antibodies. You mentioned to be able to find out whether or not you have antibodies, you could either try to enroll at one of the sites, and that would be part of the testing. There's also the Affinity Beyond study, which is a formal way in which you're trying to capture this for people. For the Affinity Beyond or at the sites, does the individual get an answer back just yes or no, you qualify, or do they also get the information about their sort of level of antibody and how much they might have fallen outside of the range?
Great question. So basically, the way it is that our assay right now for the AAV8 antibodies is a research-based assay. So it's not commercially available like what you might have available for AAVrh74 or AAV9. So because of that, what we can report out is whether or not you're positive or negative for AAV8 antibodies, and that's about it for now.
Okay.
Yeah.
No, this is a question that comes up in the
Nope. Great
community,
question.
and
Yeah,
and I think we're all thinking about this for the future. So just thank you for clarifying where we're at the
sure.
moment.
Naz, could I ask about future plans for ex-US sites, Canada, Mexico, Europe? Is the company thinking in that direction?
Yeah, we have one site that is almost fully activated in Canada, which is great. And we plan to activate up to, I think, about 4 or 5 sites in Canada as well. So that's very soon um, within our study. And then we do have plans a little further out, but we're working on them to get activated in Europe as well.
Okay. Excellent. Thank you for that. And I
Mhm.
presume that's going to be for a similar age range for boys that are currently in the US-based trials?
Yes. So for Canada, for sure. I mean, the study in Canada is going to be identical. For Europe, we're
Okay.
still trying to figure out what's the best because things might be a little different out there. We're still in the works of trying to figure out how we're going to run the study out there. And no.
Um, Getting back to, we've got a lot of questions.
Yeah.
This webinar is so well attended, and so many questions have come in. So I think this is wonderful.
Yeah.
So we talked about Givinostat being stopped, but then you would start it in after the trial was over. What about exon skipping drugs? Would that be a similar approach?
Yeah, so you actually have to wash out for about 6 months on that because
Okay.
we're trying to eliminate the influence of the exon skipping on the baseline biopsy that we have. And we don't know yet the safety of giving them, but in the future, it would be awesome. Something I'm definitely interested in, something I would internally push for, but obviously I need the backup of the company. But it would be wonderful to test the safety of our gene therapy with exon skipping drugs. It's just really hard to control for which drug you're giving and having the right number of patients to prove that it's safe and whatnot, but definitely something of interest.
Terrific. And then
And just
oh,
go ahead, Leon.
I
I'll
got
go
one more
before.
on
Yeah.
there's so many questions about
It's fine.
sort of
It's
the
fine.
enrollment criteria. So I think you've got a lot of really interested listeners. So in relating to the age requirement, So there's a question between enrolling and screening cutoff dates.
Okay.
So,
The
you
minute
know,
you sign your consent form, if you're one at consent, you're good.
okay.
Yeah.
And
And there's no upper limit for the pivotal study. So
yeah,
you just have to meet the
so
functional endpoints.
yep. So now we don't have a worry about if you're too close to 12 years old because you've broadened it out for any
Yep.
age.
Yep.
Terrific. Okay, thanks, Mike. You
No
can.
worries, no worries. I was wanting to expand on my question a little bit because I actually seen it asked online from the audience. But is there room, or could patients who are ex-US participate in the US trials?
Yes. So it's we do welcome that. It's sometimes site dependent on how they can handle that. I would say I would just reach out to individual sites that you might want to go to for the study in the US or Canada when we open them up. Um, we I think the few things that come up is I do believe, and obviously you can reach out to Regenx as well for further details on this if you're interested, but I do think you need to have some visa status to be able to stay. Some of the assessments that we do are very frequent, and so you would need a visa that covers you. I would probably guess like around 3 months of time
Mhm.
for the intense monitoring that we do. And then after that, if you want to go back and forth, that's allowed. So I think the visa is either like a B1 or a B2 visa, we'd have to know. And it would be a long-term visa that allows you to go back and forth
Okay, thanks for
into the
that.
country as
That's,
well. So
I
not
got to
just
say,
stay,
that's
but
both.
go back and forth.
Yeah, that's both very thoughtful and very helpful. I know there's families online, so they're sort of glad to hear an answer like that.
Should we switch tax a little bit and talk about some of the questions that have come in about the data? So can you speak to the percent dystrophin and whether or not there's any corrections that have been done for that based on the age of the individuals, and with the thinking that, there might be more fibrosis and scar tissue in older individuals versus younger. So if you can elaborate a little bit on that.
Yeah, so we work with an external company that does our assessment of fibrosis or fiber fatty content within the muscle tissue. And there is a calculation that is provided that kind of gives us what the fiber fatty content is of the muscle tissue that we obtain. And so we do have a correction that we do for adjustment of fiber fatty content.
Okay, great. Um, and there was another, uh, there's a question here, which I don't know that you can answer, but I know you know the field very, very well of whether or not there's any correlation between percent dystrophin expression and what you would see sort of on the NSAA or any of the other
Oh,
measures.
well, that's a great question that we are investigating. But we obviously we have too small of a number. But as we get more patients, we'll be able to do that correlation analysis for sure. And we intend on providing that with our BLA submission.
Terrific. I'm just scrolling through questions here. Another question about what to expect when you're getting dosed. So in terms of the nausea and vomiting that happens, if you could just remind us how often you see that and sort of what the timing of it is. Does it happen sort of immediately? Is it persist for a day, for a week, things like that?
Yeah, great question. So I think certain sites that we work with have a regimen in place of already preventing some of those symptoms based on their prior experience with like commercial gene therapy or other gene therapy trials of treating the symptoms before they happen. But we haven't actually required any of the sites, and we don't have a protocol for how to treat or prophylactically treat for nausea or vomiting. So some of that, I think, varies based on institution of how frequently you might have nausea or vomiting. Some of the common drugs that are used are, for example, Zofran. Sometimes when you give higher dose steroids, it could irritate your stomach, give you a little bit of reflux symptoms, but sometimes reflux manifests as nausea. So we'll give some like an H2 blocker or PPI. This is all at the discretion of the PI to kind of institute what they give. And so obviously giving those drugs can alter the presentation of how how long it lasts or how intense it might be. Typically, like I would say the symptoms start a couple days after you're infused and might stay on average, for about 14, 15 days or so, and then it resolves max. But it's not like you're vomiting all the time. It's just mainly nausea.
Okay, thanks.
Can I pick this one up? This question actually I thought was quite a good one, and it's general enough that I think everybody would like some topics around it. What is the approximate time commitment needed from a patient at the clinical site? Is plane travel required? And is there a quarantine before or after? And in that, I'm thinking about viral shedding and any information around that.
So, the required time at the clinical site varies based on how far away you live.
Mhm.
So if you live like a flight's distance, and obviously it's very inconvenient to fly back and forth, we do have tapered follow-up, so you might be seen like every other day for the first week or so, and then it tapers down to maybe like once a week, once every 2 weeks, whatnot. So once you get to the point where it's once a month, and then you move to once every 3 months, like you make a decision as a family to decide like when you're happy to go back home and kind of return to your lives and whatnot. If you have to fly out, and at that time, like we support you with any kind of travel expenses and hotel and whatnot that's needed for that. For sure. So I would say if you wanted to enter into the study, um, depending on how far you are from obviously if you're overseas, like it's a big commitment. So you have to do a lot of planning for that. If you're from within the US, if you have a two-parent home, sometimes parents trade, they're with one kid, their child for a period of time, then they go back and come back. But we're happy to support in any way possible to make your lives easier.
Yeah. What you're thinking now is whenever there's a family that may have two kids that are Duchenne and the concerns perhaps over viral shedding if one is in the study and one is not, is there any special precautions you would recommend?
Yeah, it's really hard to know for sure. So we are testing viral shedding data, but we don't have that yet ready for review. I mean, ready to present and have a good yet idea of how long our viral shedding presents itself. But most institutions have their own policies of when they expect the viral shedding to stop, but it's really hard. I've heard stories of siblings where they might have gotten gene therapy, whether it be like, for example, I'll give you a totally non-Duchenne example, say like Zolgensma, for example. If you get the gene therapy, like you might think that you're doing everything right, but there's still if you have a baby with a diaper, the diaper, or there's like
Yeah.
a blowout, like, it's really hard to manage.
Mhm.
Clorox can help, but it's really hard to manage that. And sometimes there's some cross-contamination. So I would say if any child has a sibling and wants to get dosed, it would be ideal to dose them both at the same time,
Mhm.
just to
What,
be safe.
yeah. Leanna?
Yeah, there's a couple more questions in terms of other biomarkers and whether or not you've measured, and specifically they've called out here troponin, CK, and ALT, AST.
Yep. So we use so we typically we have AST and ALT typically as safety markers. We use CK for safety and also for as a biomarker as well. So we do check that. And troponin is typically used as a safety marker as well. So it's not something that we're tracking in time because all of our patients that enrolled in our study to date have had normal troponins. Please go.
Um,
Oh, sorry.
no, it's okay.
Okay. Leanna, I'll give you about two more questions and then I'm going to wrap it up.
Okay. So there's a question about whether or not the drug reaches the CNS and what expectations might be there.
So we're not doing any studies of the CSF to know, or obviously brain biopsies to know if the drug gets into the CNS. So it'll be hard to know for sure if any of it gets
I
into.
presume the muscle-specific promoter was not expressed.
Yeah, for sure. I mean, muscle-specific promoter makes it, well, first of all, we use AAV8, so
Mhm.
that typically does not cross the blood-brain barrier. It's not known to cross the blood-brain barrier like from blood to brain. Brain to blood is a different story. So blood to brain, it's not known to cross the blood-brain barrier, and also we have a muscle-specific promoter, but you know,
Yeah, so even if the drug
I
got
never
there,
say
you
never,
wouldn't.
but you don't know
Yeah,
until you,
exactly.
yeah.
Yeah.
All right, Mike, I'll let you ask the last one.
Oh no, I'm done. I'm good. I feel like we're putting Naz through an enormous amount. I think she's doing extremely well.
Oh, that's fine. It's my pleasure to clarify anything or answer any questions. I'd rather folks be familiar with us and comfortable with asking questions and not.
Well, what we can say is if we didn't get to any of the questions that came through, or you feel like that we weren't answered adequately, we can follow up
Yeah.
by email directly with you.
Yeah. So let me wrap things up. So I want to thank the audience really for joining us here today. You know, a big thank you goes out to the whole team at REGENXBIO for the work that they're doing developing RGX 202 and really for sharing. You know, this is an important update right now. You know, as we're, I think, about halfway through the pivotal trial. We look forward to future updates from the pivotal, and it's currently enrolling patients. And I think about 12 months from today's date is roughly where we might expect the filing for accelerated approval and the BLA to go in. As Liana said, there'd be a post-webinar email that will go out to everybody tomorrow, should you have additional questions. And we'll get in touch with all attendees to let them know when the webinar is going to be posted on the Cure Duchenne website. So with that, I just want to thank everybody involved, the audience, as well as the whole REGENXBIO team, and have a great rest of your day, everybody.
Thanks for having us.
See you, guys. Thank you, Terry.
Bye. Bye.
Bye.